This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Welcome to another episode of It's Not In Your Head. I'm Justine Feidelson here with Dr. Dan Bates. Hey, Dan.
How's everyone? Hello. How are you?
Hello. Good.
It's always weird when we kick off like this because we've been talking for an hour now and it always feels a bit odd. But anyway.
Because we have to do the fake formal intro to then dive into the episode. But we are really looking forward to covering what we have to go over with you guys today. It's something Dan and I have obviously been talking about since the inception of this project with regards to why is it called It's Not In Your Head and what are the challenges that patients have to deal with when that is how pain is essentially explained to them. And really the inspiration for this episode came from one of my own patients who's also a practitioner. She's a therapist who works with a lot of chronic complex pain bucket type of patients as well. She is one of those herself, obviously. And in talking about the Empower You conference, she brought up a really good point of why would the patients who are burned by the traditional medical system be drawn to this? And that is the challenge when, even in the work that I do, that's the part of the patient population that I see, the part that has kind of turned their back on the traditional model, has unfortunately had a lot of really negative consequences from being told that pain is in their head, which I see all the time. That's why they unfortunately end up with me, because they've exhausted other options. They haven't been able to have other professionals who see and understand and validate, frankly, what they go through and have experienced. And even worse, you tend to get kind of labeled and actually like pushed away and cast away. I see often from the traditional medical system. But what was really interesting and enlightening and, kind of ironic in some of our conversations with Dan was that from the provider perspective, you actually don't realize this to the degree that I, as a patient, do. And obviously having my own like built-in biases with who ends up with me, right? The patients that have really gotten the rotten end of the stick. Is that everyone? No, but it's a more significant chunk than I think most providers realize, which was kind of interesting to me, but makes sense, actually.
Yeah. So from my side, Justine shared the message with me and it was a WTF moment where I was like, hang on, what's the harm of this? And like the initial discussion
and I'm like, what?
Hang on.
What do you mean?
I was like, hang on. And like I knew that, when someone gets told that it's in their head and they get blamed and shamed for it, for their own pain, like I knew it upset people because patients come into me all the time and they cry. And so you don't have to be Einstein to work out that it has an emotional harm to it.
Right.
And so I didn't think about it beyond that. I didn't like go, well, what are then the further consequences of that? And so there's the first piece of patients exit the
traditional
like
medical
the Western
system.
traditional medicine center. And the consequences are they then roll over into a bunch of other therapies that have, less scientific evidence about them and, some other larger questions, either around efficacy, safety, or financial viability. And that, some people take advantage of people with chronic pain and take a lot of cash off them. Yeah. And it became very apparent to me that the reason why I never thought about it is because I'd never seen the consequences. When I, in the past, have got it wrong and delivered the message incorrectly, which I have, I don't see the consequences of that because the patient never comes back.
Right.
And so because the patient never comes back and never actually goes, by the way, you're an idiot. What did you make me feel like that?
This really messed me up.
By the way, I'm never. And these are the you just don't know.
And I don't trust doctors anymore. Right. There's no.
Yeah. So you just don't know about it. So you don't think about it as a medical practitioner. So then I went, okay, let's start digging down the pathway into what is the potential harm around managing or around telling somebody it's in their head. And how does that then come out? And so that's really where this started.
And Dan, if I can interject for a second, I think what's really interesting, right, is to me, because of my own personal experience and me seeing that piece of the patient population, it's common sense. Like of course it's harm, but you actually need to look at a fair amount of research and studies to show, not just from an opinion perspective, well, what is the harm,
Yeah.
And that's kind of the rabbit hole that Dan then
Yeah. So
went down.
like I've then run down like the rabbit hole of what is essentially called iatrogenic psychological harm. You can go to PubMed, look up iatrogenic psychological harm or iatrogenic harm. If you put in psychological component, it's very much more relevant to this discussion rather than iatrogenic harm, which just basically means anything that a clinician does where there's a negative outcome is iatrogenic.
Medical
the psychological
trauma.
harm piece is one that is not reported very much. So that's where I start going down this rabbit hole. And so one of the things that I was already aware of is that within the allied health world, so allied health essentially includes physiotherapists or physical therapists, psychologists, chiropractors, osteopaths, exercise physiologists, et cetera, et cetera, et cetera. Right. Particularly within the exercise literature, they're not very good at reporting harms. There's a Cochrane review on the efficacy of exercise for chronic back pain. And they looked at like 18 meta-analyses that had looked at 381 individual studies. Only 25% of those studies actually tracked harm. So 75% of the research doesn't even look at whether harm takes place. And that's really, really common. And anybody that works with somebody who's got chronic pain, particularly get them to do some exercise, you blow them up sometime. Like someone, it's not a... I mean,
that's why movement is so challenging, with this population, because everyone has to deal with those very negative and real consequences of movement.
Yeah. So
especially when not ideally done.
We know we flare them up, but it's not actually reported as like within the literature. So number one, harm within the allied health literature is just not reported. No one even asks. So we don't report it very well.
Yeah.
The other thing then is if you then step into psychotherapy, which is when we're talking about different ways of explaining how pain works, whether it be pain neuroscience, whether it be, other versions of that, they are all psychotherapies. You can put them underneath that bucket. And so what does the literature say about harm in that group? And
those
once again,
groups,
it's like really underreported, and it's really under-researched, but it's there. There's pretty much one study that effectively says that the rate is about 5%. And it's 5% of patients experience a long-term negative impact from psychotherapy. Now, they don't define long-term, and they don't actually define what negative impact is, but, negative impact and long-term. So we can go with that. There's also some data from the NHS, so that's the UK Health Service, that says that it's about 1 in 20 patients suffer a negative effect from psychotherapy, which 1 in 20 is 5%. So kind of those two numbers at least match, and it gives us a bit of a ballpark to say, well, we kind of expect that patients, 5% of patients are probably having a negative effect from psychotherapy.
Right.
Interestingly, though, one of the things that they quote is that younger patients, so young adults, tend to have a greater effect. And so they're more likely to have a negative effect from psychotherapy. So, our older patients probably cope with it a little bit better. Our younger patients cope with it a little bit worse when it doesn't go right. I find that
too. Yeah. And I think there's an acceptance time of dealing with it too. Like when you're 20 years old, you just want this to go away and get gone. When you've been dealing with it for like 15 years and it's a part of your life, you have a different perspective.
Yeah. And I think that, anecdotally, although we don't have any data on, what's the harms of pain neuroscience, but even though we don't have like direct data, we've got anecdotal data. Like in my experience is that I get enough patients every week that come in upset, distressed, cry because someone's told them that their pain's in their head, that at least anecdotally it's there. And now let's be honest, I have a biased population. I have a reputation for telling it the way it is. And so I think which is another way of saying I'm blunt. So I think that people say, go see Dan, he'll just tell you the way it is. And so I probably have a biased set of patients that are upset. So
receive that well, yeah.
Yeah, it's there. And there is significant harm about it. And so what does it matter? So the underreporting, so who cares? But the flip side is...
Well.
So where is there another example of where harm has not been reported And it's been shown to be there quite significantly and
But
having
it
a
exists.
negative impact. The answer to that is chronic fatigue syndrome. So 2011, there's a randomized control trial done looking at patients with chronic fatigue syndrome. And what they're doing is they're comparing CBT, so cognitive behavioral therapy, and GET, which is graded exercise therapy, and looking at what the effect is with patients with chronic fatigue syndrome. What they found and it's a big randomized control trial. It's not small. There's a lot of data that's going into this. And so what they found at the end of this study was that 22% of patients recovered and 60% of patients had significant improvement. Okay, so that sounds great. However, here's the plot twist.
Dun, dun, dun.
Halfway through the study, they changed the outcome measures. So there's words for that. We won't bother saying them here, but there's words for them. And they don't actually justify why they changed the outcome measures. However, when they do the reanalysis, so they go back. So Wilshire and co. in 2018 go back and redo the analysis on the original outcome measures. And the results shift a fair bit. So what it shifts to is that the recovery rate is 7%, not 22%.
22, right.
For CBT, and it's 5%
for graded
exercise therapy, which is no greater than the controls. Okay, so substantial difference. When they then look at harms, the number of patients that report harms are 54 to 74% due to graded exercise therapy.
Which is why patients are so scared of exercise. Like
that's a WTF moment.
Yeah.
And so that had massive implications. So that's at that point in time, this is only like 2018, it's not very long ago. What was recommended was CBT and graded exercise therapy. That's how we're meant to manage chronic fatigue syndrome. But
how
now,
it is treated.
What happened? The CDC, which is the Center for Disease Control, they don't just do infectious diseases and COVID. They do recommendations for everything. They shift their recommendations for management of chronic fatigue syndrome to then say that CBT and graded exercise are then contraindicated. And so that is a massive change for when you actually report
a 180.
Something. Yeah, it's a
from
180.
Helpful to contraindicated.
Yeah. So if we then apply that to our chronic pain population, where at this point in time, we don't report harms.
You don't look at them. Yeah, I can't report.
We don't know. We don't know whether our education models at the moment, whether our psychotherapy models at the moment actually do more harm than they do good. So not reporting harms, it's a big deal. It
perpetuates the harms. And that's what's like forever fascinating about this discussion is how obvious it is to patients and how not clear it is to providers.
Yeah. And I think that's
what the downsides are.
Yeah. And let's double click on that point. It's so obvious to patients. Yeah. And so if it's so obvious to patients, you know what, there's a problem there. Like you don't have to be Einstein to work this stuff out.
Right.
There's something going on. Now, do we have the data for it? The answer is no. We don't have the data for it. But let's be honest, if we go actually looking for it, it's going to be there.
Yeah. And it's certainly more than an opinion, right?
So we then dive into what's the big deal? Like, I think what is the harm?
Right. Define harm. What are we talking about here?
And I think the biggest problem with the phrase that we have issues with is the words, it's a misinterpretation of a signal. We'll talk further about the whole misinterpretation concept. But those words get translated by patients into, you think I'm imagining my pain. You're telling me this is in my head. So what's the consequences?
Well, and also I can't really help you because then as soon as you say that's the reason for your pain, insert these psych therapies, which can affect the amplifiers, but are not addressing the cause. And now you've diverted attention even from the cause. And so that's where then hopelessness comes in, where not only have you kind of labeled and judged me, I don't know how I can change this then. So it's very negative for patients because the therapies provided are not very helpful. And then you're going, so then what? Now what? Yeah.
This blames the patient. And the other thing that, though, from my perspective, and I think, I've sort of said this before, as soon as I tell the patient that, or I indicate or I use the wrong words and it gets translated in their head that you're imagining your pain.
Right.
What's the effect of that is I lost them.
You can't help them. Right.
But I've shifted to blame. Like I'm blaming them. And so it limits my ability to then be able to help them.
Right.
Because I've damaged the relationship and the trust.
Right.
Like that is such a big issue.
Right. And that really is the core issue. Like going back to the intro about the conversation with my patient, was that the patient provider relationship challenge. And why does it break down? Where does it break down? So we'll have a whole nother episode where we actually tease that apart and kind of build on this discussion, but that's at the root. Why does that happen? Because of this poor translation, which sometimes is in an effort to make it simpler and easier to understand for the patient, but it gets heard wrong. And then that's equally as damaging, even if it's well-intended at times.
Yeah. And the other thing is like patients feel judged.
Right.
They get accused of using, like, being resource wasters,
wanting
drug
attention.
Seekers,
right. Wanting attention.
Malingerers, wanting attention. Like the whole
you want to
secondary
be
gain.
Yeah. Illness behavior. Like even terms like illness behavior, like, yeah, you're trying to explain a set of behaviors and you can remove judgment from even that term, but it's a label. It doesn't feel good to be called that. It's not positive. So that happens over and over and over again and over the span of years, right? That's where you get terms like Dan was like, what exactly do you mean by medical trauma? The trauma that is garnered from years in this system, and how that makes patients feel. And then, where you go from that is very bleak with a lot of disorders. So if you can, provide therapies without providing the harm, that's kind of what we want to get to, is mitigating the harm. Because some aspects of these therapies, as we get into, are really helpful and are really impactful. And a lot of the things that I do with patients too affect mindset, context, psych factors, amplifiers, right? It's not valid, but it's who is it best for and in what situations. And how are you communicating that is the most key piece of that. And
within that is also the other piece is that patients can avoid care. Like they don't move to a point where they get diagnosed. And what's the point? Even when they've got a condition, the condition can then progress without them then seeking care. Right. Or you just develop something else.
Yeah. Well, the amplification grows. The amplification, like all of these positive feedback loops develop. You do get sicker and sicker, and then you are hopeless. Yeah.
And I think, look, we'll dive into in the patient-provider relationship episode. We'll talk more about how is it that what's happening for the doctor that results in
why does it happen?
This discussion. But I think going from the opposite side of things, let's say the misinterpretation of a signal is it's a brain-focused explanation of pain.
Right.
Okay?
Right.
If you use a explanation that is whole nervous system, so this is a whole nervous system. So what you've got is you've got a whole combination of, you may have a noxious signal that you can, or maybe you can't diagnose, or maybe you've diagnosed it and you can't treat it, or
turn it off.
You can treat it, but you don't want the treatment. Like let's say that you don't want medications, or you don't want a 4-level fusion. Okay. That is okay.
You don't want stimulators.
You don't want a stimulator.
Fair.
That's okay. But then what happens is then you get peripheral sensitization. So peripheral sensitization is when the peripheral nerves or the nerve endings become hypersensitive. It's wiggle time. Giles is wiggling. Actually, it's exercise time today.
It is actually. It's exercise time. It is wiggle time.
But then what we've got taking place is then once they're sensitized, the dorsal root ganglion, which is the nerve root, it becomes hypersensitive, and it's wind up. And then you get at the back part of the spinal cord, that gets wound up. And then up at the brainstem, so then you've got these steps within the whole process where you've got amplification. So by the time
so many stops.
By the time it actually hits your cortex, it's a disproportionate signal. And so that disproportionate signal is then being perceived as quite severe pain and severe danger. And so
appropriately, actually, by the patient. It's just
that it's a disproportionate signal.
Right, to begin with. Yeah.
To begin with. It's not a misinterpretation of
the signal.
of
The signal isn't
where,
quiet. The signal isn't quiet, and
yeah,
the patient's feeling it is strong. It's
yeah,
loud, and the patient interprets it as such. Yeah.
yeah.
But
The consequences of taking a
the
angle that is
misinterpretation route.
not a misinterpretation of a signal, and the big one, the one that we all run into, and this is the one we're always trying to balance up, is harming the patient because we over investigate them,
Right.
or because we over treat them. That's always the thing that I'm struggling with about, how do I not hurt this person? You do an MRI on somebody, I'm telling you, you're going to find something.
You know what's interesting? Not psychologically hurt them further too, actually, like not just physically potentially, because you can get in quite a space where it's hunting, searching, finding. You're desperate to find like what's wrong with you. And sometimes that can be like positively reinforced, especially if the provider lacks communication, and that's a challenging situation. But that can also be harm in over investigating inadvertently, depending on the patient, right? Most patients I wouldn't say that for, but there are some who even
Yeah.
that is an amplifier that you've
Oh yeah,
exacerbated.
absolutely. Like MRIs are absolute amplifiers, and the amount of people
Yeah.
who will come in with an MRI with mild degeneration of a 4-5 disc, where really what they've got is sacroiliac joint pain or facet joint in their
It's not even
back.
what's on the MRI, right?
It's not what's on the MRI, and
You just created more
but
stress though.
they see
More
it,
fear, right? Yes.
and it drives the fear. So like, it's not like the other
Yeah.
end of things, the
It's
other
not bullshit.
side
Yeah.
of things doesn't have risks. It does.
Consequences also.
But
Yeah.
we've got to balance it up. Yeah, and we acknowledge that. And so it's difficult to manage, but you have to
We
manage
can
it.
manage it better, right?
If we switch back to then discussing, what's the harm of somebody interpreting what you say to them as
Right.
they're
A
imagining it,
misinterpretation
with the
version.
normal message being it's a misinterpretation of signal.
Right.
And the one we haven't mentioned yet this so far is suicide.
Yeah.
And suicide risk.
Yeah.
And these are very interesting numbers, terrifying numbers actually. So in 2023, Patrick Ryan, who is part of the office of the clinical director at Bethesda, published a study with a number of other clinicians. And so this is a great study, and it's of 720 inpatients. So you're an inpatient, it's like things are a little bit worse than being an outpatient. So they're probably a relatively struggling group, but nonetheless, like it's not a small study for this type of thing. And what they did is they were looking at what is the effect of chronic pain and helplessness on the likelihood that you're going to answer a set of questions that indicate that you've got increased suicidal risk. So I'm going to read the questions to you because the questions are not mucking around. So
to get straight to it.
In the past few weeks, have you wished you were dead? Yes, no. In the past few weeks, have you felt that you or your family would be better off if you were dead? Yes, no. In the past few weeks, have you been having thoughts about killing yourself? Yes, no. Have you ever tried to kill yourself? Yes, no. And the final question, are you having thoughts of killing yourself right now? Yes, no. Please describe. Okay. They are not mucking around questions. And okay, if anybody is listening to this and you just answered yes to any of those questions in your head. So in Australia, you can call Lifeline. The number for Lifeline is 131114. And if you can't call 131114, you can call 000, which is, Australia's emergency number. Giles, what's the numbers in the US?
Yeah, in the US, you can call 988 is the suicide lifeline. And you can also actually text home or do a WhatsApp chat to 741-741. Very important resources.
So if we come back to that, they are like hardcore questions. So having a risk of chronic pain increases the risk that you answer yes to one of those between 120% and 443%. So that's chronic pain. Separately, having hopelessness or feeling hopelessness about your medical situation increases your risk of answering yes to those questions between 560% and 1200%. Wow.
Yep.
That is
It's
That are crazy
massive.
numbers.
Yeah, because those two things combined create suicide. Like,
Mm.
that's the progression. I'm hopeless. It's hopeless. I'm a burden. No one can help me, and this is my fault. Everyone would be better off without me. I can't imagine suffering like this for the rest of my life. It's also the calculation that's often made. Being misunderstood, all these things lead to severe depression. And when, you know, like I think about even in situations where it wasn't a super negative medical experience, where for me, even with CRPS, once I had just exhausted the good medical options, it was this like terrifying lump in my throat, kind of like, but what now? How do I live the rest of my life though? Like, that's still very overwhelming and daunting. And so for me, because of past stuff and, being in a very challenging living situation and being like super, super determined to not have this just be the rest of my life, it kind of galvanized me. And, it allowed me to be like, if no one else can help me, like, I'm fucked and only I can help me. Like, I'm the one who can change this. Krish can implant a stimulator. Different practitioners can help me with certain pieces. But the problem is that a lot of patients don't respond that way to that situation, and that's not their fault. And if I had different factors going into it, I think I also would have veered much more, give up. And this is like the last thing I can handle more of. So, exhausting the medical system, even when it's not a terrible experience, is difficult, let alone when you add on all of those really negative things along the way. And on top of it being flagged as a problem, which then often leads to those type of patients getting even less help, right? They're the ones, childhood trauma, they have personality disorders, they have reasons doctors don't want to treat them, they have reasons doctors don't like them, and frankly, a lot of it's valid. But when you have certain life experiences and you have insight and empathy to some of the reasons people end up like this, it makes you angry in a way that you want to help them, not that you don't feel for them. So the harm, it's so obvious, like I say, to the people that live through these types of things. When you have a symptom you can't imagine tolerating forever and you pair it with hopelessness, what else would you feel?
And the thing that guts me is that, you know, we, I may have generated some of that hopelessness in somebody because the way I phrased something, because the way I said
Right.
something, because I got it wrong, even if it's unintentional,
Yeah.
like that is enormously distressing, like from a doctor's perspective.
Yeah.
And so what I wanted to just step into is something written by a neurologist from Harvard in 2019. So this is Dr. Matthew Burke. And I'm just going to read this out straight out. I'm going to read a reply as well to this because it kind of contextualizes things to a certain extent. So it starts as, "It's all in your head," is a phrase sometimes said by physicians to patients presenting with symptoms unexplained by medical disease. As a neurologist specializing in neuropsychiatry, nothing bothers me more than overhearing medical colleagues proclaim this one-liner at the bedside or snickering about these patients during rounds. Unbeknownst to them, I also hear my patient's version of being on the other end of this phrase and find myself constantly trying to repair the damage that these words can cause.
Yeah.
Here's a reply. This reply is from Blake O'Laven. He's an MD, and he labels himself as mostly retired neurologist.
I like that.
And
Mostly
his
retired.
his simple reply is, "It's hard to call this an epidemic since it's been a forever in medicine."
Yeah, that ties in perfectly to the History of Hysteria episode, where Dan and I basically go through the entire chronological order from witchcraft and wizardry all the way to functional somatic, right? How are we labeling and looking at and treating patients who present in these medically unexplainable, ways? But even that itself, the whole like medically explainable thing is that it's a bias. It's kind of a perspective. It's a general perception really on what those symptoms are, but not medically unexplainable.
Medically unexplainable. It's just
Which
as we've
is,
already said. Like
we don't
we
even treat
either
them.
the doctor either or the clinician either lacks the knowledge, expertise, skill to diagnose it, or we just simply lack the
You can't.
technology.
Right.
You know what? If you want to come to me and talk to me about rashes, I really quickly get to the end of my knowledge base. Like it is
If I could help you with
like that
rashes.
is I do not step very far
Yeah.
past it's red, and that's kind of like, or it's a bit like I got nothing.
What if I have a rash on the most painful part of my back? Then would you
Okay.
take it? Think about it.
Anyway, but so that's a massive knowledge deficit that I have. But that doesn't mean that their rash is medically unexplained. It just means that I don't know.
This is also where, like, these types of patients, you end up in a bunch of different specialties. You end up seeing a bunch of different doctors who, a lot of those doctors' skill sets aren't going to be like what you're dealing with. So it's not even just a pain physician thing. It's an in general, I think, thing when you have these type of symptoms, because there's a lot of people who are like, I don't do rashes.
Yeah. So then the question then becomes, does actually telling somebody it's in their head or having the patient reinterpret what you've said as it's in their head actually result in hopelessness? And I think there is a ton of papers out there that pretty much show that patients with medically unexplained symptoms go on to feel like they're not being taken seriously, that they are being told they are crazy, that they then exit the medical
Western
system,
sort of perspective. Yeah.
that they are weak.
They brought it upon themselves.
Yeah.
You know,
So,
it's like,
and that they do exit and they do generate hopelessness in these patients. And I think, you know, there is quite a large paper that was written, I think it came out, some guys in the Netherlands, I can't say his name. Anyway, published 2021. It's a paper looking at somatic symptoms and their association with hopelessness and helplessness. It is strong. Somatic symptoms are another way of saying somatic symptom disorder. That's another way of saying somatoform disorders. It's another way, in many ways, of saying medically unexplained symptoms are very strongly linked with helplessness, and they are linked with hopelessness.
Hopelessness, yeah, right.
And so then the next question is hopelessness linked to an increase in suicide risk. And quoting from Racine, she wrote a systematic review of the risks of suicide in chronic pain. Taking this as a quote, mental defeat, pain catastrophizing, hopelessness, perceived burdenness, and thwarted belongingness are all associated with suicide outcomes. So I think that we're sort of starting to build a picture that says, well, we tell people that it's in their head, it increases hopelessness, and then it increases
suicide risk.
It increases suicide risk.
Right.
And so, you know.
And it's so interesting because everyone talks about how important it is to have hope, but no one thinks about how fucked you are if you are hopeless. Like, it's the opposite. And if you've felt, you know, any of those adjectives before suicide, you know how closely they're linked and how much of a slippery slope that is. And when you start to accumulate, right, diagnoses, again, that are untreatable, uncurable, there's nothing we can do to help you, how else could you feel? So if you can better investigate, better treat, better explain, right, use the treatments, use the therapies, but avoid the harm. That's, I think, what Dan and I are trying to encourage physicians to do. And hopefully, you know, if you're still hanging in there, if you're a physician and you're open-minded enough to absorb this, we were chuckling that like only patients are going to listen to this episode in full. But if you're a patient, hopefully you know, feel seen in a way that is significant, because part of what Dan and I were chatting about earlier too, and why this episode is so meaningful to me, is that, look, I don't have doctor or MD next to my name. And me saying these things doesn't matter as much as Dan saying them. And if Dan can see this and we can couple it with the research where it's not, you know, my opinion or my patient's experiences, it's backed by not just logic and common sense, but you can, you know, tie this all together. And so if as a physician, your goal is to decrease, you know, the harm that you potentially cause to patients, this is a good way to do it.
Let's bring it together. Unexplained medical symptoms are explained as a misinterpretation of a signal by multiple groups. And so ASHA, in their study 2022, published like 22 and 23, they very much directly link chronic pain to medically unexplained symptoms, and they explain it as a misinterpretation of a signal. And so we know that this is that is commonly translated by patients as, you're crazy, this is in my head, you're lazy, you know, you're imagining your pain. But even more bluntly, like as Matt Burke wrote, patients just are bluntly told, this is in your head. And I last week, I had a patient that was asked by his work cover case manager, "You sure this isn't, you're not just imagining this?" Like, he used those words. I was like, what the hell?
It's like, it's just because it's so offensive when you're on the other side of that. Like, why would you ask that of somebody? But it really doesn't, I don't know, connect.
So the guys from the Netherlands have shown that patients with unexplained medical symptoms, that it produces helplessness and hopelessness.
Right.
And Racine has linked hopelessness to increased suicide risk.
Right.
And the question is this: if engendering hopelessness in a patient results in them answering yes to one of these questions.
Any of those above questions, yeah.
Yes, in the past few weeks, you wished you were dead.
Yeah,
In the
I don't wanna
past
be
few
here.
weeks, you felt like your family would be better off if you were dead. In the past week, you have had thoughts of killing yourself. Have you ever tried to kill yourself? And are you having thoughts of killing yourself now? But increasing the risk of saying yes to any of those by up to 500 to 1200%. Like,
It's a lot.
this is not a harmless approach.
Right.
And
You just don't see the harm.
We just don't see the harm. Like, the patient
Right.
just doesn't come
They don't
back and
come
talk to
back.
us.
Right.
So we just don't see it.
No.
And that is potentially in 5% of our patients, 1 in 20.
Yeah.
What about
it's
if
a
it's
ton
not?
of people?
What if it's not 1 in 20? What if it's 1 in 100? What if it's 1 in 1,000? Like,
It's still,
what is it?
right.
Is it
with
does
other
it
things we accept risk
is the
of.
point is that we come to accept? And so that's a really good question. So
Yeah.
what's a comparator to this? If we look at a medication,
What would we accept?
what do we accept from a medication? So there was a medication called Rimobant that was a cannabinoid receptor antagonist.
Yeah.
It had weight loss effects, and it was used to decrease cardiovascular risk, I believe was the
Original.
This study was back in, I think, 2010, 2011. It was a massive study, like gigantic. 18,000 plus patients,
Jeez.
randomized control trial, over 9,000 patients in each arm, multiple studies. Like, the dollars that they spent on this must have been out of control, out of control dollars. So they had an increased risk of suicide. And so what they had is they had 4 patients in the treatment group complete suicide.
Wow.
Compared to 1 patient in the placebo group. And for those who attempted suicide, they had 9 patients in the attempt group versus 5 patients in the placebo group.
So that's twice as much.
So the risk here of completing a suicide was 0.04%, not a 500 to 1200% increased risk of that. And
Right.
we don't know
0.05.
We don't know, to be honest. We don't know. It's not a direct comparator because they're comparing like actual completed suicide to the suicide risk, a 0.9% risk of a suicide attempt. All right. So now we're getting sort of closer to, answering yes to one of those questions. So it's not a direct and it's not necessarily 100% fair, but it is a very low risk. And so that drug got pulled with a 0.09% increased risk of suicide attempts. So you need to get, that's essentially I think you need to get about 1 in 10,000, basically.
Right. We were talking about 1 in 20 in the past.
And the data on, is 1 in 25%.
Yeah. 0.9% versus 500 to 1200%.
Yeah. So even if it's if it's 1 in 1,000, even if you put it to one,
drug was way less,
1,000,
and it would not be tolerated. That's the point.
1 in 1,000 is your risk, which it looks like it might be as high as 1 in 20. Even if you say it's 1 in 1,000 of your patients, you increase their risk of suicide. That's 2.5 times what we'd accept from a medication.
Right.
Like, seriously?
Right.
And so this
is where I try to not lose my shit. Yeah. I'm like, Remain calm. Remain calm. Yeah.
So the counter argument
It's a
to
big
this,
deal.
yeah, it's a big deal. Okay. And so the counter argument to
Significant.
this is that it works. Okay. Hey, we do
Right.
this and we use this technique because it works.
Great.
My patients don't get in my hands. My patients don't have an increased risk of suicide. I do an awesome job. And
Right.
the benefits I see outweigh that risk, like in my hands, no problems. So what's the data? So that's a risk benefit ratio. We do this all the time. Like medicine is about risk benefit ratios, and that varies based on the individual. And we do that all the time. When I'm doing a spinal cord stimulator on somebody, I am like, we're weighing up risk benefit ratios in that. Okay. We do have good data on pain neuroscience. And so there's been some meta-analyses done now looking at what is the effects of pain neuroscience. And so here it is. So for pain neuroscience, on a 100 millimeter scale, you get a 5.9 millimeter improvement in pain. So that's a half a point. If you're on a 10-point scale, that's going from 7.5 to 6.5, basically, or 7.5 to 6.4. On a disability scale, a 100 millimeter disability scale, you get a 4.9 millimeter improvement. So you're going from 7 down to 6.6-ish, 6, whatever.
Yeah, 6 and change.
6.6. Okay, 6.5. From kinesiophobia, so that kinesiophobia is the fear of moving, so you're scared to move. You do get a significant effect, so you get about a 13.55 millimeter, 13. So you're getting a 1.3 millimeter decrease.
Because you're really targeting that.
Of kinesio. It's only 13 millimeters out of 100. Like, it's not exactly like, for me, that's not a big effect.
Not super compelling, even so.
And for catastrophizing, you get a 5-point decrease in the catastrophizing out of a 50-point scale. So the benefits are relatively small. Right. And so I suppose the question is, then you're going to look at your risk-benefit ratio. So what we have now is we have a technique or an explanation.
Right.
The explanation is this is a misinterpretation of a signal or whatever versions it is. And you then have, based on the data, you've got small improvements in pain, small non-significant improvements in disability, small but statistically significant improvements in fear of movement, and small but statistically significant improvements in, I would argue that both of those are clinically insignificant.
Irrelevant.
Is it worth the risk that you might increase suicide risk by 500 to 1,200% in up to 5% of your patients?
Yeah.
Do the math for yourself, really.
Right. So, then the question becomes, well, how can you use aspects of the technique that are helpful and valid and appropriate for aspects of pain and specific populations, compared to others, which we'll dive into. But it really just comes down to how can we do better in the communication and the messaging that accompanies techniques that are really critical for filtering and downregulating and distracting and, creating sensory substitutions so that you're not consumed and overwhelmed by a noxious signal that is very overwhelming and intense. And if you can't, make it go away, find it, fix it, you have to have other ways of managing it, which are the pieces of pain that these therapies are getting at. But let's do that without a 500% risk in the downside of what can happen, because it's hard enough to live in chronic pain that's hard to treat. Don't make it harder for the patient.
Clearly, 100% agree.
I concur. But yeah, that's basically our point, right? This is, you can explain pain, just explain it properly, explain it fully. And I think if your intention has been to make it simpler, and that's where maybe you've inadvertently created some harm, like, a lot of patients want to learn. I don't know that you always have to dumb it down to the level that it's a miscommunication of a signal. So if we can kind of go recognize, right, there's neurological changes in the nerves, then we're getting into the nerve roots, then we move on to spinal cord, then eventually, you get up to things going on in the brain, sure. But it's both, right, finding the causes and the inputs and then addressing the neuroplasticity pieces as best as you can once that's the case.
Yeah, you can use techniques that alter neuroplasticity, that alter selective attention and filter out components of patients' pain, without telling patients that it's in their head, which
Right.
results in blaming, shaming, and the potential risk of harm.
Right.
And that's the key. Can you deliver this therapy that is certainly effective for some people,
right,
but can you deliver it without the risk of harm? And the answer is, well, we think yes.
Yeah.
Clearly.
I think so.
So
Well, I do with folks.
So in the next episode, what we've got is we're going to break down pain neuroscience. We'll look briefly at, the model of the brain as a prediction generator, within the context of chronic pain, and have a look like, what's good within these, where did it go wrong, or where's it going wrong, and how else might you, think about it, and how else might you present it.
Yeah. So, I mean, it's kind of like a drug that you could administer either with or without a side effect. And what we're trying to get done is just administer the drug without the side effect of potential suicide. Like, it's not that hard. So,
not that hard.
But to be fair, it can be hard. So that's why we want to develop clear, ways of substituting the misinterpretation of a signal piece, because I think that's particularly where then it's in your head. And if you could avoid that piece, you wouldn't even get to the how much am I imagining this, or is this my fault type of piece. So yeah, I think that's pretty much what we wanted to go through today. All right. You guys can also actually now, besides heading to the website at www.iniyh.com, you can also now sign up for a newsletter. If you just add a /newsletter to the end of that will also be in our show notes. And that's where Dan and I will be providing kind of additional context, thoughts, and things around the episodes that we release weekly as a way to give you guys some additional content and lessons to take.
All the resources. So basically all the papers that we dig out to discuss around these topics. And what we do try and do is I'm not trying to give this as opinion. I'm trying to give this as this
factual
is what I think,
information.
Yeah. Here's the data that actually supports the opinion. So please, if you want to dive into some of those papers, please do.
Yeah. Thanks a lot, guys. All right. We appreciate having you. All right. See you next time.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.